Hello, everyone. This is Congresswoman Allison Schwartz. And as you know, I'm President and CEO of the Better Medicare Alliance. And we hope you are all well and staying safe. And if you are in the Northeast, managing through this really heat and sunshine, as well as, of course, the challenges we've had given the COVID epidemic. So welcome to the webinar. This webinar is really offered as an inside look at telehealth usage and policy. Both before and the months just after the COVID pandemic hit communities across the nation. We are unveiling a new research report commissioned by Better Medicare Alliance and conducted by ATI Advisory. We also have two panelists who will respond to the report a little bit and most importantly, speak about their own firsthand experience in what it's been like to transition care delivery from in-person to telehealth visits so abruptly during COVID. Finally, we will also offer some actionable recommendations for next steps to use this experience to move forward towards an ongoing use of technology-enabled care. It's no secret that we're seeing a paradigm of a shift in telehealth as a result of the pandemic. CMS data has shown a dramatic increase of more than 12,000%, that's almost hard to say, 12,000% in telehealth usage. CMS reported 9 million beneficiaries in traditional fee-for-service Medicare receiving telehealth visits as of mid-June. Over 3 million of those used audio only. Consumer research that we have commissioned about beneficiaries' experience with telehealth overwhelmingly showed a positive response to telehealth visits. It was a survey of about 1,000 Medicare Advantage beneficiaries. 91% who used telehealth to fulfill a doctor's visit or clinician's visit reported favorable experiences, and 78% said they'd be happy to try again. Yet the poll also showed that only 24% of those surveyed had actually used telehealth services during the COVID pandemic. This was in May, so these numbers obviously could have changed. The research that we present today shows that there are barriers. Internet access and usage remain a barrier for many, especially those over the age of 75. Many beneficiaries lack the proper tools, such as a laptop or a smartphone or a tablet, or access to the internet. And many of them complete their telehealth appointment through audio only because of lack of access. So traditional fee-for-service Medicare payments have also inhibited the full realization of telehealth benefits for the enrollee population. Some of those have been lifted, some of them remain. So we know there's more work to be done to build out the possibilities of telehealth and what they can do and do the most good for seniors and actually for everyone else across the nation. Good news is that there's keen interest amongst policymakers in telehealth, not only because it is really manage patients and get care to patients during this public health emergency. And we acknowledge that CMS has done a good bit in waiving requirements and opening that access. But it's also a real question of how it could be used in the future. Seema Verma, the administrator at CMS, declared in a recent op-ed that, quote, telemedicine genie is out of the bottle, and there's little reason to unduly confine this advantage to the pandemic. Congress is just as interested with bills having been introduced and others drafted in how to extend the use of telehealth, making today's webinar particularly timely. We look forward to discussing all this in great detail with three outstanding panelists. We have Allison Rizer, principal at ATI Advisory. I'll introduce more detail in a minute, who will give the report presentation on the findings, followed by Dr. Philip Ciampa, who is Chief Innovation Engineer at Atrius Health, and Natasha Khouri, who is Associate Vice President of Telehealth Solutions at University of Pittsburgh Medical Center Health Plan. Both Atrius Health and UPMC are ally organizations of BMA, so we thank them for being allies and thank them already for the really good work they've already done in getting care to patients during this pandemic. During the course of today's event, a little housekeeping here, you can ask a question of me or the other panelists at any time by using the chat function in Zoom. my good staff will be watching this, and we'll gather those questions, and they'll be read aloud at the end of today's program. We hope to get it to as many as possible. If we don't, by all means, email us or let us know your question and comment, and we'll try and get you an answer. So before introducing the first panelist, I did want to share a quick word about the research BMA is doing and is unveiling today. The new report, which is entitled Telehealth During a Time of Crisis, Medicare Experiences During COVID-19, is being shared exclusively with you for the first time. We will send out a link of this report, so there'll be lots of numbers you'll see, but you'll get all of this in the report following today's event, and with an email containing the report tomorrow, when we will actually distribute it more publicly. Further publicly, I guess this is public as well, but it coming to you first. The research was conducted by ATI Advisory. We work with them. They've been really good consultants to us. They work with us on providing this kind of analysis, and they've done a really good job on this report, as you'll see. Also, it is the first report that is being released by Better Medicare Alliance with our new sister organization. It's our research arm, which is called the Center for Innovation in Medicare Advantage. The mission of the Center for Innovation in Medicare Advantage is to present the evidence, the quality, cost effectiveness, and value care provided to Medicare beneficiaries by conducting and broadly disseminating nonpartisan, timely, credible research and analyses on what is happening in Medicare Advantage, and identify recommendations to enhance and improve coverage and care for Medicare beneficiaries. The new center will allow us also to do even more of what we do frequently, which is hosting convenings and roundtables that bring together thought leaders, experts, plans, providers, community partners, and advocates to lend their guidance and experience and expertise to exploring key issues around Medicare Advantage. Thank you, if any of you have been a part of that. It's really been an important part of how we develop policy positions and commentary. We're excited to introduce you to this new extension of the BMA community. So look out for a slightly different logo with BMA and with the Center for Innovation in Medicare Advantage. And look forward to upcoming reports that'll be coming in the next months ahead. So with that, I'm going to turn it over to our first speaker, Allison Rizer. And Allison is principal with ATI Advisory. She has a wonderful first name, of course. She's spent nearly 20 years of health-related experience involved, including over a decade focused on insurance and government programs. Before joining ATI, she most recently served as Vice President of Health Policy and Strategy with United Healthcare, where she led organizations' policy efforts specific to duals population and Medicaid. Prior to that, she was Medicaid Policy Director at United Health, and previously with the Lewin Group. So lots of experience. She has a master's in health science and health policy from Johns Hopkins, and a master's of business administration from the University of St. Thomas in St. Paul, Minnesota. So with that, Allison Rizer, well, thank you for your work done on this, and look forward to your reporting the findings to everyone.
Thank you, Congresswoman, and thanks for the opportunity both to share the findings today, but also to partner on this really important study. Good afternoon, everyone. My name is Allison Rizer, and I am with ATI Advisory, and I'm going to walk through our study findings today. If you could go ahead 2 slides. So first, just a quick overview of the policy landscape related to virtual care and telehealth, and also a quick overview of how we approached this study. Next slide. So in general, there are provisions in the Social Security Act that define what telehealth is permissible in the traditional Medicare fee-for-service program. These are provisions like originating site, which is where the beneficiary is located, distant site, which is the location and the type of rendering provider, and the modality, which is really the technology that connects the beneficiary to the provider and what is permitted as reimbursable through Medicare fee-for-service. Medicare Advantage plans are able to offer telehealth access above and beyond this in a more expansive manner if the plan files this benefit in their annual bid process with CMS. And then, of course, as you all know, in January, Secretary Azar declared a public health emergency, and in March, the president declared a national emergency. And then both of these actions allowed for subsequent emergency waivers that we'll talk a little bit about today. Congress, CMS, and states have been implementing really unprecedented waivers in an effort both to maximize access to care, but also really to help individuals remain safely in their homes. Next slide. So the waivers that were specific to telehealth generally focus on who, where, and how telehealth can be provided. First, who can provide telehealth? During COVID-19, this has been expanded to include federally qualified health centers, rural health clinics, certain allied health professionals like physical therapists, for example, and providers that might not have a prior relationship with the Medicare beneficiary. Before COVID, these provider types generally were not permissible as distant site providers in Medicare fee-for-service. Next, where telehealth is permitted is also something that has been waived through COVID-19. So COVID-19 waivers eliminated originating site requirements, including allowing telehealth to be delivered in the home, whereas previously a beneficiary had to travel to a facility or a doctor's office to receive telehealth. Also prior to COVID, Medicare fee-for-service telehealth was only allowed in rural areas of the country, rural counties, health professional shortage areas, but this restriction also was lifted during the public health emergency. In terms of how, CMS added more than 100 new service codes eligible for telehealth reimbursement during the emergency. Audio-only services became more expansively reimbursable, and certain platforms like Skype and FaceTime became permitted. And then finally, CMS also implemented certain other flexibilities, like allowing Medicare Advantage plans to make mid-year benefit changes in their benefit packages. Next slide. So there were two parts to this study with a heavy focus on stakeholder experiences, including plans, providers, vendors, and of course, beneficiaries. We interviewed 17 different organizations during May and June with broad diversity in their geography, their specialty area, and their organization's size. We also analyzed the Medicare Current Beneficiary Survey, the MCBS, to quantify Medicare beneficiary access to internet, really given the historic focus on internet sort of framing a core requirement for telehealth. And with that, next slide, we will jump into the findings, and one more. So first, our findings from the MCBS analysis. The MCBS doesn't explicitly ask whether an individual has internet access in his or her home, but it does ask about frequency of internet use, which can actually be a really good proxy for access in the home. And what you can see here on this graphic is that among all beneficiaries, at the top there in red and gray, about a third of Medicare beneficiaries likely do not have internet access in their homes. These are individuals reporting that either they don't use the internet at all or they use it only a handful of times per year. What you don't see here, but we did also analyze, and you will see in the report that the Congresswoman is sending out, was that within the Medicare population, internet use also varies quite a bit based on age, income, urbanicity, and somewhat based on Medicare Advantage enrollment. So for example, unsurprisingly, we found pretty dramatic difference in internet use based on income level, with low-income beneficiaries about 7 times more likely than high-income beneficiaries to report no internet use. Similarly, internet access peaks in those aged 65 to 74 and then drops pretty dramatically among those older than age 75, which can make it really difficult to help this population remain in the home. We also found that internet use was lowest among individuals who live in rural areas compared with more urban areas. And then finally, we found a small difference between beneficiaries enrolled in Medicare Advantage and those in the traditional fee-for-service program, with slightly higher use among those in fee-for-service. Next slide. So as I mentioned, we conducted structured interviews with 17 different organizations, including health plans, providers, vendors, as well as policy thought leaders. There certainly was some variation in experiences and perspectives, but generally across all of the organizations we spoke with, we heard some consistent trends, comments on what has helped scale telehealth and virtual care during COVID-19, what you see here referred to as accelerators on this slide, as well as comments on what some of these barriers are that have impeded even broader growth of telehealth during the public health emergency. Next slide. So first, in terms of accelerators, Perhaps most importantly, we heard one key accelerator across nearly every single interview that we conducted, and that was risk bearing. Whether it was providers who were capitated through their Medicare Advantage plan partners or Medicare Advantage plans themselves receiving capitated payments from CMS, we heard pretty consistently that risk-bearing afforded organizations some flexibility to modify their workflow and expand telehealth. For example, risk-bearing providers reported not waiting for fee-for-service waivers to catch up to Medicare Advantage payments, and using their Medicare Advantage margin to expand telehealth solutions for all of their patients across the fee-for-service and Medicare Advantage spectrum. And in the case of Medicare Advantage plans, they were able to lean on administrative activities and medical and quality improvement activities to expand access to telehealth. Another consistent theme we heard was the importance of using the home as the originating site. This obviously allowed beneficiaries to remain more safely in their homes, but it also provided convenience. One of the trends we heard was that behavioral health no-shows actually decreased during COVID, likely due to this convenience of remaining in the home and also the expansion of telehealth to non-rural counties. And finally, CMS expanded the providers, the services and the modalities that were reimbursable during the public health emergency, including allowing audio-only services. And audio-only services ended up being a pretty large contributor to access during the public health emergency and continues to be. So taken together, these policy flexibilities, they absolutely have been critical in providing access during a time when individuals, many of whom have limited access to internet, have been confined to their homes. Next slide. So next are the barriers. Just as we heard consistently that risk-bearing was an accelerator, we heard consistently that the Social Security Act fee-for-service provisions were a barrier to faster uptake during the public health emergency. So I mentioned on the previous slide, these provisions generally have all been waived during COVID-19, which has been helpful generally. But what we heard across most of our interviews was that these provisions actually were a deterrent to providers to invest in telehealth infrastructure prior to the public health emergency. Because it's difficult to invest in something when a large portion of your patient population, your fee-for-service patients, can't use it. And similarly, this lag in fee-for-service has meant that fee schedules haven't caught on or caught up, which has created challenges for Medicare Advantage plans in some instances to build out appropriate payment levels. So while waivers during COVID-19 have been really important and helpful, the longstanding fee-for-service policies themselves essentially moved the starting line back, if you will, that without these restrictions, providers would have been more advanced and ready to respond when the virus hit, because they would have been more likely to already have an existing infrastructure. And as a result, their Medicare plan partners likely would have had a broader network of providers with telehealth capabilities. Relatedly, process validity in the Medicare Advantage bid process causes fairly conservative approaches to telehealth in the Medicare Advantage space. Medicare Advantage plans must specify in their bids exactly which services will be available through telehealth. And so they tend to limit these benefits to only those services that they are confident a year in advance will have providers with telehealth capabilities. So this, in effect, prevents Medicare Advantage plans from really keeping up with this rapid evolution that we're seeing in telehealth. Plans just submitted their bids to CMS in early June last month for the 2021 contract year. And they are locked into that bid for all of 2021. So if a new provider type builds out telehealth and virtual care infrastructure, those aren't going to be reflected in the bids that went in last month, and those plans won't be able to cover those benefits for those specialty types. Another challenge with the bid process is supplemental benefits. Medicare Advantage plans are allowed to cover some internet and devices through supplemental benefits, but there are pretty considerable guardrails that can make it difficult for plans to use their supplemental benefits to do this. For example, depending on how the benefit is filed, plans might have to lock the internet or device so that beneficiaries only use it to communicate with their providers, and that can be difficult to do, and not necessarily in the best interest of beneficiaries who would benefit from functionality like being able to connect socially with family members. During COVID, many organizations loaned devices and tablets to beneficiaries, but we heard pretty consistently that they were concerned about their ability to lock these devices and limit their functionality. And as a result, they did it outside of the supplemental benefit construct. They used administrative approaches or clinical model dollars, for example. And then finally, for those organizations serving dual eligibles, we heard that policy and program interactions between Medicare and Medicaid were a pain point. This was somewhat state specific. We didn't hear this across all of the organizations, and it was based on the state's program designs. In some instances, plans have been unable to find vendors and technology that can integrate across Medicare and Medicaid. And in other instances, Medicaid policy waiver approvals in a given state may have lagged behind the Medicare policy waivers. And this caused situations where plans had to continue doing in-person, face-to-face activities for dual eligibles, particularly those with long-term services and supports needs. Next slide. And then most importantly, the glue for how all of this works is the beneficiary experience, with telehealth and virtual care. So first, in terms of demographics, we heard that beneficiaries who speak English as a second language were more comfortable with informal platforms, for example, Skype and FaceTime, than they were with traditional platforms. I alluded to this a little bit on the previous slide. Another statistic that is important as we think about telehealth and virtual care access is that a substantial portion of Medicare beneficiaries don't have cell phones. I'm not talking smart devices, like just basic cell phones, which obviously makes interactive video-based telehealth difficult. And it's a reflection of another finding that the Medicare population highly prefers audio-based virtual care. Again, this was not necessarily every single organization we spoke with, but by far most of them reported that the Medicare population highly preferred audio-based virtual care. In some instances, it was a reflection just of sheer access to internet and devices. And in other instances, it was because beneficiaries felt that the video interaction was invasive into their home and into their personal appearance. And then finally, access generally. Access is challenging among lower income beneficiaries. Most don't have devices, most don't have internet, and those who do have a cell phone don't want to use their limited minutes on telehealth. And then we also heard when possible, beneficiaries like consistency in providers. That is, they prefer to continue with their own personal practitioner if possible, but that they also appreciated the convenience of the rapid access that they got with vendors when their own providers did not have telehealth capabilities. Next. And so that brings us then to opportunities and recommendations. A lot of really rich information, and I'm going to talk briefly around how this might look moving forward. Next slide. So many people have commented on this. Telehealth has advanced, 5 to 10 years over the past 4 months. In-person care is still very important and often essential, but virtual care has been instrumental in preserving access during this public health emergency and even expanding access for some individuals. Again, if you think back to the behavioral health point that we heard about no-shows actually going down during the public health emergency because of telehealth. And it's important to build on this momentum, certainly in an appropriate way, but it's important for policymakers to learn from these experiences regarding what works, what should be preserved, what should be expanded. So I'm going to talk a little bit about some access opportunities and then process and payment opportunities. Next slide. So first is access and removing long-standing fee-for-service prohibitions that sit in the Social Security Act. Waiving these provisions during COVID has been really important in getting care to people who are holed up in their homes. And these flexibilities typically already exist in the Medicare Advantage program, but by removing these provisions, or at a minimum, lessening them in the fee-for-service space, Congress and CMS would generate more interest in the provider community generally to invest in telehealth, which would increase access to services across the fee-for-service and Medicare Advantage populations. This could include eliminating originating site restrictions, allowing beneficiaries to receive some services in their homes, expanding reimbursement of telehealth to all geographies, not just rural geographies. This could also include allowing more provider types to serve as the distant site provider, including physical therapists, occupational therapists, speech language pathologists, as well as FQHCs and rural health clinics. It could also include allowing Medicare beneficiaries to access telehealth and virtual care, even without that prior relationship with the rendering provider. Another opportunity is to permanently allow the broader set of services that have been made permissible during COVID, now that CMS has some of that claims experience and a better understanding of how utilization will work with expanded telehealth services. And then finally, in terms of access, really important is allowing audio-based virtual care to continue at some sort of payment parity level, at least for certain services, to ensure that Medicare beneficiaries without access to reliable internet or Wi-Fi or video-enabled technology can in fact get some of the care that they need. Next slide. So other opportunities also exist around payment and process. I touched on payment parity just very briefly on the previous slide. Better alignment and payment for virtual care and payment for in-person care would help to grow telehealth. There definitely are some costs that are built into in-person payment rates that may not make sense in a telehealth encounter. For example, costs associated with medical gowns and face masks. But generally, there is a need for an updated fee schedule to reflect the growing telehealth and virtual care trends and to allow for parity where it makes sense. Another process and payment opportunity that I haven't touched on, but that has also been important during the public health emergency, is risk adjustment. There may be instances or specific beneficiaries for which virtual and telehealth actually expands their access to care. But if Medicare providers and Medicare Advantage plans aren't able to capture that person's actual level of need for risk adjustment purposes, it could create a disincentive to offer virtual care. So allowing risk adjustment in certain circumstances when an individual may be unable or unwilling to have an in-person encounter is something to consider. And then finally, the Medicare Advantage bid process restrictions that require plans to specify those exact services that they will allow telehealth for. Again, this essentially locks a plan and its enrollees into whatever technology is available in June of a given year for the entirety of the next year, for 18 months essentially. But technology and uptake right now are advancing much faster than that. And the bid process, really should evolve to keep up with that changing pace of providers investing in new technology solutions. For example, allowing some sort of mid-year flexibility, or maybe not requiring Medicare Advantage plans to specify exactly which services will be allowed through telehealth. Next slide. And that's it. I know we've got Q&A at the end, but also invite you to reach out if you have any questions. And with that, I will turn it back to you, Congresswoman.
Great. Thank you, Allison. Really appreciate that. Okay, so moving quickly right along, and thank you. There was a lot to absorb, but I think it brings truth, I think, to both of our panelists. Next, we have Dr. Philip Ciampa, and he, mind you, is the Chief Innovation Engineer at Atrius Health. And again, you may want to describe Atrius as the large multi-specialty provider with a long history in Massachusetts, again, an ally organization of BMA. He leads their telehealth program since its inception in 2016. He had received a medical degree and completed his residency training in internal medicine and pediatrics at Vanderbilt, and completed a fellowship at the VA, Veterans Administration National Quality Scholar. He's a practicing primary care physician with a career that is focused on transforming health systems to better meet the needs of patients in settings as diverse as Middle Tennessee, urban Massachusetts, and rural Mozambique. So interesting geographies, and look forward to hear you tell much about how you transitioned and your experience with telehealth.
Thank you, Congresswoman. We can go to the first slide. So I'm grateful to share with you some of our experience transforming our practice during COVID-19. Next slide. So just a minute about Atrius Health. We are a multi-specialty medical practice in New England. We have 30 clinic sites in Eastern Massachusetts and care for nearly 750,000 patients there. We have always bought into the concept of accountable care and have accept full risk across the entire continuum of care for our patients. Next slide. So when thinking about what virtual care looked like at Atrius before COVID, it really felt relative to today like prehistoric conditions for us. We had been testing and piloting video visits since 2016 across a range of applications, some of which were well established in the community and others were fairly new. And while we had a lot of clinical success building programs that both patients and providers valued, we had a lot of challenges in scaling up those services across our organization to pass the pilot scale. And some of those challenges have been enumerated in the prior presentation with regards to our Medicare patients regarding originating site restrictions and patients' homes as ineligible sites of care, but also just things like determining insurance eligibility for our patients seeking telehealth prior to a visit and how much those visits would cost our patients out of pocket were challenges we were still working on and hope to solve this year when COVID hit our community. Next slide. Next slide, if you don't mind. Thank you. So in early March, it became pretty clear that the pandemic was going to affect our community in Eastern Massachusetts. Fortunately, there were some actions taken by the federal and state governments to help remove some of the barriers that we had faced prior with respect to telehealth. We discussed the waiver a second ago for Medicare. It was pretty instrumental in helping us start to begin to offer these services to our patients in their homes. On a state level, Governor Baker, with an emergency order, had established parity for both video and audio encounters and reimbursement on par with office care. And that was very helpful also in getting us started with offering these services more widely. At the same time, on the 23rd of March, non-essential businesses were closed in Massachusetts, which meant that we were offering face-to-face care only in emergencies and shifting most of our care to the virtual space. So at the same time, when telehealth became critically important for us to maintain our continuity with our patients during the crisis, we also had actions that helped us to decrease or remove barriers that previously had prevented adoption. Next slide. So our first goal became to establish telehealth for COVID-19 evaluations. And we knew that telehealth had some opportunities that presented themselves to really help us deal with COVID the best we possibly could. Number one, we wanted to reduce the risk of in-clinic transmission to high-risk populations, including our providers and staff. We had a strong need to preserve PPE supplies that were in short supply at the beginning of this pandemic. And we knew that most patients would have mild symptoms, where conservative care with home isolation were appropriate interventions in many cases. So we organized a centralized call center to help triage patients with COVID-like symptoms. We staffed it with some specially trained nurses to do initial triage, to route patients that called with moderate to severe symptoms to in-person care, but then to schedule telephone or video visit evaluations for patients with more mild symptoms. These visits could be scheduled on a central pool so providers could see patients more or less on demand, working as teams. And we used a mixture of provider types, including nurse practitioners, physician assistants, and physicians in primary care, medical, and surgical specialties to staff the service. We scoped these visits as essentially enhanced triage, designed to determine two questions. One, does the patient seeking virtual care need an in-person evaluation subsequently based on their signs and symptoms? Or does the patient need to be referred for COVID or other testing like flu? And if needed, patients could be routed to specialized urgent care centers or set up for drive-through COVID testing as needed. Next slide. So within 2 weeks, we trained about 100 providers to do virtual visits. And before long, our call center was averaging 400 calls a day. On the right, you can see that fewer than 11% of those calls needed a face-to-face visit as an initial pass. 27% of our patients calling in were managed essentially with home monitoring. An additional 12% were referred for direct testing, and half were offered a virtual visit. We've completed about 13,000 of these virtual visits to date to evaluate possible COVID-19, about half on video. And we have done about 30,000 tests with about a 10% positivity rate over the course of the pandemic since that time. So this call center and virtual care was a pretty instrumental part of how we addressed the pandemic. But we also knew that this was just a starting point, and we were concerned about the remainder of our patients and their clinical needs during a time of crisis when physical distancing was still important. Next slide. So our next goal was to really then turn and establish telehealth for the rest of the care that we normally would provide. And as I mentioned, as soon as essential businesses were closed, we had a few challenges right away in terms of having to reorganize our clinics and consolidate sites into those seeing respiratory conditions and those that were not to prevent transmission. We canceled most of our routine in-person care, and within a week or two, our volume was down about 90%, as you might expect. We then adopted a virtual first strategy for most of our low acuity care. To do that, we trained over 700 providers in weeks to conduct video visits across all of our service lines. And we deferred to clinical leads in each service line and to individual clinicians when to essentially bring someone in for care. So taking an opt-out approach rather than an opt-in. We built systems also to help patients directly schedule certain types of virtual care through our online patient portals. Next slide. This slide is just depicting a bit of how the adoption of virtual care went over the early stages of the pandemic. And you can see below that right away after physical distancing was put into place, that our office visit volume in dark gray went down dramatically, partially supplanted by telephone calls, which are light gray, and video visits in orange. Soon after rolling out video visit training across our practice, you can see that over time, adoption of virtual care and increasingly video visits as a component to that virtual care increased dramatically. And relative to where we started with 500 video visits done between 2016 and March 12th, 2020, and where we are today, where we're seeing about 2,500 video visits a day, there's been a 2,600% increase in our volume, even relative to the first weeks of operation. So really a dramatic change in our practice over a very short period of time. Next slide. So once we sort of accomplished that rapid adoption, we then turned our attention to evaluating how we were doing really across clinical, operation, and technical dimensions. We first sent a patient survey to the 290,000 subscribers of our e-newsletter, and we had a great response. Although our respondents tended to be older than our general population of patients, they had a very high rating of their experience, with 88% rating their experience doing a video visit at 7 out of 10 or higher. And 92% of the respondents that had a visit plan to do another one in the future, regardless of COVID-19. We then turned to our providers and we completed a survey on their experience doing this virtual care in such a short amount of time with such a large, rapid change. And despite those challenges, most providers were satisfied with their experience to date conducting virtual visits. They felt that video was amenable to treating chronic health conditions, completing annual wellness visits, addressing behavioral health concerns, and also addressing many low acuity acute problems where the history was more important than the physical to do an evaluation. And based on that experience so far, they estimated that about 40% of their practice could remain virtual in a post-COVID world. So we have several works in progress right now that we're focused on and trying to improve the experience for both patients and providers completing these visits. We're looking to incorporate other team members in the virtual care experience and providing support to our patients at the front of visits through medical assistant rooming. We're optimizing the performance of our technical platform and adjusting that experience. And we're also looking at our clinical protocols as reopening of our practice continues to better integrate virtual with in-office care. Next slide. So what does the future hold for us? Well, we're thinking about the fall first and trying to stay vigilant and prepared should a second wave of COVID-19 occur locally. We are in so much better position though than we were in February with regards to readiness, with a now developed experience amongst our workforce and also lots of experience among our patients completing these visits. We are working hard to anticipate what changes may take place in the regulatory environment of telehealth post-COVID. If we go back to where we were in February, we're going to have those same challenges that prevented us from offering these types of services to the majority of our patients to the degree that we have during COVID. And the uncertainty around what those changes may be is a major challenge for us right now in predicting the future of telehealth within our practice. We are working to define the best clinical and operational practices for virtual care, just basing on our extensive experience that we've developed over the last 5 months, not just determining what that 40% of virtual care will look like for the long term, but really how to incorporate that into our overall care model integrated with office-based care. And last, at the end of the day, we've built and replicated essentially a virtual office visit. We know that digital health's promise goes way beyond that. And so we envision building out new things like using asynchronous tools like e-visits or pre-visit check-ins to marry with video to improve efficiency and thus improve access. We are looking at ways of specializing certain specialty expertise while still allowing a broad geographic access to these services. And we're looking at ways that we can use telehealth to continue to bring care to the homes of our high-risk frail patients. So we're really in the first hour of this transformation, and we have a lot to learn. But I think hopefully one of the silver linings of this epidemic for us has been all of the experience that we've generated and hoping building a system of care that comes out of this epidemic that's stronger than it was before. So thank you.
Really appreciate terrific that you've actually done all those numbers and surveys and gotten reactions from both your providers and patients. So we'll hopefully have some time for some questions from the audience. Let me quickly move on to our next speaker, who is Natasha Khouri, who is with, as I said, it's Telehealth Solutions, Vice President for the Telehealth Solutions at UPMC Health Plan in Pittsburgh. And she has the role of supporting the plan's strategy and delivery of telehealth solutions, including coverage and reimbursement, provider and member engagement, and the development and management of innovative telehealth programs. So Natasha had worked previously for Aetna for 11 years and worked as well on Aetna's international virtual primary care program. So had a good bit of experience on V-Health by Aetna. Interesting. She's a graduate of Duke University and Harvard School of Public Health. So Natasha, you can dive right in. Very different kind of health system than Atrius. So good to have both perspectives.
Yeah, and thank you, Allison. The report is so spot on to our experiences. So it's really refreshing to see that in that way, making sense of the last, crazy 4 months. And really excited to hear Dr. Ciampa's comments and the provider perspective. So I'm at UPMC Health Plan, and the UPMC system overall, large, 19 billion annual revenue, not-for-profit health system, 45 hospitals, over 5,000 affiliated physicians, treating member patients in 6 states. Our health plan covers about 3.5 million lives. And we have a venture capital arm, UPMC Enterprises. So integrated delivery and financing system, really interesting, unique way to sit or place to sit. So completely concur with both a lot of the payer observations from the report and the provider observations. So obviously I don't have to say, the environment for telehealth has completely shifted. Allison made the comment 5 to 10 years, I might say 20 years. In terms of pre-COVID, I would say UPMC Health Plan had a good head start. We had really gone kind of all in on telehealth starting back in 2016. We had partnered as a health plan with our provider system to begin investing in provider training for tele. We had built an on-demand telehealth program for our health plan membership. And so we had a good head start there. We had a good member engagement campaign around telehealth. And then in 2020, when CMS offered the opportunity for Medicare Advantage plans to build telehealth into supplemental benefits, we took full advantage of that as a health plan. So our 2020 Medicare Advantage product had robust coverage of telehealth for primary, specialty, behavioral health. We had adopted the stance of pay parity for telehealth with in-person care. We felt like that was a really important thing to do for our provider network, to help them kind of get started. We wanted to remove any barriers they might have to doing telehealth care. So when COVID arrived, we already had a medical policy in place. We had a perspective about reimbursement and coverage. We had a network engagement plan and communications already out there. And I think that really helped us move quickly to leverage the changing regulatory environment to meet patient needs when COVID hit. So, mid-March, we began to see uptick in cases in the region. We had a regional, the quarantine began. And so we used our platform, to do a lot of press and member engagement around telehealth is a good first entry point. It's your triage system. It's a safe way to get advice and care. Start there. Use our on-demand telehealth program. We can triage you into in-person care or testing as needed and guide you through your quarantine and through the guidance from the public health department. So that was, we began seeing a surge in telehealth on demand initially. And that, has transitioned over the last few months into high volumes, both in acute care and then routine care and now preventative care. So we started seeing, specialty and primary care and behavioral health visits all shift from in-person to scheduled video visits, beginning, mid-March, and, went up to, I think, we're doing 10,000 or more video visits and phone visits a day. We expected our owned providers or employed providers at UPMC to do high volumes, but even our affiliated network, just across the state, we saw just a really rapid, immediate transition into virtual care, which was super exciting and good to see. And then I mentioned preventative care. So as a health plan, we've quickly moved to see, how can we continue to do things like annual wellness visits, Medicare annual wellness visit via tele. So we developed some provider training around that and member training around that. And in April, starting in April, we began to see about a third of our annual wellness visits be happening in tele. So we're really trying to figure out how to keep people getting the care that they need, despite this time. I would say, considerations as we go forward, I would, completely echo what Allison said. We need, as health plans for providers, some regulatory clarity and stability, and for that that landscape on tele to open. Where CMS and the states go is really key. Because I think if fee-for-service coverage is not there, it's very hard for providers to be able to invest in making kind of a real transformation of their care delivery processes and the way that they schedule and treat. And there's a huge amount of opportunity there. There's just so much we can do beyond, taking an office visit and putting it into video. That there's a lot more we can do to totally change the way care is delivered and financed. I would echo comments from earlier that telephone is really important. We see that as well from our membership. As a health plan, we had some maybe healthy skepticism about the use of phone for telehealth. We just certainly did not bar that in our medical policy on tele before COVID, but this has definitely made us think, that this is going to be a critical component of virtual care going forward, and we need to kind of dig in there more and support that and figure out, as was said earlier, what are the optimal areas, the optimal mix really between video and phone, in person, and even digital app-based types of care modalities. What's the right mix of that to provide the right care and reflecting differences in what populations need? So I would also, echo again, there are disparities in access and in health outcomes, and technology can help support that or exacerbate that. And so we've been thinking and working actively with our FQHC and RHC partners to figure out, how do we help them build robust virtual care programs that, go in and understanding the barriers that are Medicare, and we have a SNP membership as well. That this membership, it may not have, as was said, the hardware, the data access, the comfort, and we need to design programs with, diversity, inclusion in mind, because it's just sort of a whole different environment of providing care when you're providing into the home. So those are some of our reflections. So I'd be happy to speak more offline and, participate in some questions from the audience.
Okay, terrific. Interesting that thank you both, Phil and Natasha. Thank you so much, and Allison, for your presentation. And as we're going to see if there's some questions out there, because there's a lot of content to go through. There's a lot of consistency, and yet there's some differences as well. But one of the things that I did want to ask you about, and this was something that came up in the report, was that how prepared both of you were. Not as prepared as you hope to be, but more prepared than you might have been. And I think there are two ways of thinking about being prepared. One is the fact that you were already using some telehealth. So at least, there were people within your organization. There was understanding about how you might pay for it, how you might actually roll this out. But secondly, you also, because of Medicare Advantage and the framework, particularly I think you mentioned this at Atrius, that you kind of knew who your patients were. It was first the worry about COVID, but then, and you pointed this out also, Natasha, there were all the other of your beneficiaries, your patients, who had, particularly in the senior population, have really multiple chronic conditions. And so being in touch with their provider was extremely important for them to know what was safe, what was possible. Everyone knew that doctors' offices were closing, and some held back because they feared, I don't have COVID, so I should just hold out. Obviously, elective surgeries, elective procedures were all canceled. So talk a little bit, if you could, about how everyone's worried about COVID. Anyone can get COVID. Seniors are more at risk. But that other population, which is really most everyone, particularly seniors, who really needed care during this time, and how because you had either a capitated payment and the ability to move some dollars around, be able to move doctors around, that you were more prepared potentially to do that, and what do you think that means for the future? So, Phil, you want to start with that?
Sure. No, thanks. I think that we were prepared probably more than we might have been if we had not had a telehealth program, even in its infancy prior to COVID. And so, the fact that we were an accountable care organization gave us the ability to experiment with telehealth even before it was clear how that would serve our patients at scale. And having that infrastructure in place and having a lot of familiarity with that infrastructure in place allowed us to essentially take our 5-year plan and turn it into a 5-week plan, as opposed to just writing it from scratch. So I think that's absolutely right.
Natasha, you have anyway, I know UPMC, and I was thinking of a pace for,
We were prepared, but, as you said, could have been more, right, in hindsight. And so we have a large clinical organization of care managers and coaches, nurses, and we quickly redeployed those to call our most vulnerable members. We kind of identified, who would be those folks we really need to reach out to immediately to find out help them make a care plan for this new environment, because everything that they were probably doing on a daily basis or expect, none of that is true anymore. And so what did we need to do in terms of getting them their meds, in shifting care, from office to home, deploying folks to the home if needed, figuring out whatever it might need to be. I think that was really helpful. And we had surveyed our provider network before COVID and did after as well. But we had a directory of what providers were available via which ones could do a video visit or a phone visit. And so we could kind of match people up to make sure, this is the care you need. Let's find out if your provider can do it, or if not, let's get you connected. Let's set up a video visit for you with this type of provider who can do that. So I think those were some of the preparations that came in very handy.
Right. And I think both of you mentioned this, but just to amplify it, is that population within Medicare is pretty different as it is everywhere else, but it's not only the medical needs can be great, but also their resources. And so, you have a plan, so you have a special needs plan, people who are eligible for Medicare and Medicaid, the issue of just income and location and mental acuity, all of those issues are obviously compounded by age. So how did you just deal with people individually? Would you actually want to make sure that policymakers really understand that this is a really diverse population with diverse needs, and having the flexibility to be able to meet those needs is extremely important. I will say, particularly about audio only, there's a real hesitation on the part of some policymakers about this is just going to explode unnecessary care, that this is going to be real problems in program integrity. How would you address that? These are how do you make sure they're clinically appropriate visits now? I'm not talking about bad actors out there, but there are always some of them. But how do you make a system that gives some of those policymakers who are maybe worried about the federal dollar and Medicare, and Medicare Advantage is a little bit different because they get a capitated amount. You can talk about that. So having the flexibility to use the dollars that you might within that amount. But how would you address that? The whole issue of, should we be worried about that, or is that really not the thing to be worried about right now as we go forward?
Yeah, that's a great question. I'm sorry, Allison, I didn't mean to cut you off. I think, Natasha, you said it really well, and that I think that we're at a stage now where the digital technology can either exacerbate or address some of the disparities we face. And I've seen that in my own panels. Telephone has literally been a lifeline in connecting with people during this time that had no alternative. And we know that diabetes is still happening. We know strokes are still happening, and being able to connect and do what I normally would do in the room on a telephone, at least with regards to assessing history and making plans with patients, has been absolutely a lifesaver.
Yeah, those patients. Natasha, want to add to that?
Totally agree. And I think we just need to kind of invest in order to learn more and, open the door, right, and figure it out. And this issue, we really just don't understand enough about, I really appreciate, Allison, the comment or the slide, your opening slide about beneficiaries and how many of it have interacted with the internet, right? And that's really helpful. I've never seen that kind of data before. And I think we know that there are gaps in access to the key technologies and the comfort level, but how big are those gaps? And what are programs that solve them? There are things around, deploying iPads or phones out to the home. Does that work? Does bringing someone into an FQHC where they can get what's going to work? I really would love to to participate however we could, figuring that out quickly, because
I think when I ask if there are any questions of the audience, I hope so, but it's really the ability for Medicare Advantage to have more flexibility, whatever fee-for-service, is going to be important, because that's where we'll get the learning from this experience. We really will, and we need to do that. So we hope the fee-for-service will also make some changes, originating site, some of the who's eligible. We know that those underserved communities exist in urban and suburban areas too, and not just rural areas. So we hope that those things change, and we will work towards that at BMA. But we want to maintaining that flexibility that plans have. And I think, Allison, you pointed out this bid process does lock you in, particularly when you're moving so quickly. I know a number of plans just said go, and a number of providers said we're just going ahead anyway. We'll worry about payment later. We'll figure that out. Or we have capitated basis, so we have some dollars to move around, and we have some ability to do that, which was a huge advantage during this whole COVID. It was not reliant on a fee-for-service system. There were some dollars to be able to do some of these things with, and just really, we're also going to push very hard to make sure that kind of flexibility remains. I don't think there's much threat to that, but still, keeping track. I encourage you, keeping track of what you're doing, sharing that with us. At BMA, we might want to take some of the words that you both did and sort of turn that into something that we can give out to people as well. Would just be great, because everyone's been very hungry for real data and real understanding, because we've gotten a lot of anecdotal data, and including a conversation I had with Atrius a few months ago. Now that you have it in slides, it's a whole different way we might be able to deal with it. But UPMC has so many more patients even, be sort of interesting in a different geography. Let me just ask my staff, are there questions that the audience might have? I could go on, but I know we're also sort of at time. But Jonathan, do we have any questions from the audience?
Hi, Congresswoman. Yes, we have a question from Rory, who asks, can we get a little more detail about why providers aren't billing telehealth services as SSBCI again? And as a follow-up, what kind of flexibility would we need to inject into SSBCI benefits to allow for that billing?
Maybe we should let Allison start.
Yes. So you want to think about the supplemental benefits kind of in two constructs. There's the primarily health-related benefits, and then this SSBCI acronym that Rory has in the question, the special supplemental benefits for the chronically ill, which is a mouthful. The primarily health-related benefits are in terms of internet access and providing devices. You can only do that in the primarily health-related benefit space if you lock the device so that it results in provider communication. So for example, a person couldn't use that device to maybe FaceTime with family. And so that is one challenge in the primarily health-related space. SSBCI is a little different. You actually can allow pretty expansive access in that device and in the internet space in SSBCI, but there are other guardrails. So SSBCI by definition has to be limited to an individual who has a specific chronic condition. And so there are these different limits. It's not also necessarily about what providers are billing for, but how plans are thinking about it in terms of how they're filing their benefits. The other piece then outside of supplemental benefits is in kind of the broader medical Part A, Part B benefit package. Health plans are also allowed to file telehealth in that Part A and Part B space, but they've got to be very prescriptive, I would say, about exactly which services they will allow for telehealth for, you know, the next 18 months. And so there are these different moving pieces. And I think generally speaking, echoing Natasha, just more latitude in how to deploy those benefits, I think would be really, really useful.
So it's, and also SSPCI benefits are fairly new. So that's the, you know, so again, this is the flexibility that plans had was decided a year ago. So unless they wanted to actually, again, open it up in other ways on the clinical side, which does provide some opportunities. And I think that is, and I think many of the plans did encourage providers, particularly full risk providers. I think you could, maybe you should ask, what kind of conversations did you have or did you not need to have in terms of the conversation you might have had with your plans now? You know, in terms of, can we do this? Are we limited? You know, or did you just go ahead and do it and say, we'll have that conversation later? Or did you get some help from the plans or ignorance, or how did that relationship play out? Now I know UPMC has its own plan, so, but still the different people, the different ways of looking at this. How did that work for either of you? And Natasha, maybe you want to start on that?
Yeah, well, you know, there wasn't a lot of data on either side, right, to predict. And there was sort of the fear was, well, you know, what's going to happen? There's going to be an crazy explosion of telehealth care, which sounded nuts, you know, in summer of 2019, right? So it turned out to be actually the case with COVID, but I think it did take a lot of, there was not a comfort level, of course, within the plan about what type of utilization we would see, what provider take up or member take up would be. So it was definitely an uncomfortable conversation, but I think it was, you know, well, if we don't step forward somehow, you know, we won't learn. And we sort of have a gut faith, right, that this is the direction that care is going and that there's an opportunity here, so much opportunity for access as well as cost management, right?
And I think also in the beginning, there was a real question about how much COVID would take over, not just the hospitals, but everyone, you know. In the beginning, there's a little bit like, I think holding back on the part of all providers is saying, I don't really know what I'm supposed to do about everybody else, you know, because in some places, if you were, you know, depending geographically where you were, it was overwhelming and hospitals and doctors were overwhelmed. So, and there was no PPE and all of those things were really kind of difficult, but it really took probably all the attention in the first few weeks just to figure that out. Yeah. But Phil, do you want to add something to that conversation?
No, I think that's right. I mean, I think that our conversations early in the pandemic were entirely around COVID, and we were going to do it regardless of what happened structurally, because we had to, for all the reasons you just indicated. And we didn't know in March, was this going to be, or we're going to be in, you know, the situation Italy was in, or we're going to be in a different situation. We didn't know. And so that was really where most of the conversations happened. Fortunately, some of the structural things that went into place helped us by not having to go payer by payer, but being able to be payer compliant like we prefer to do when we're offering services.
Which speaks to, and the next question, we're going a little bit over, I think people will be interested in this, is just, you talked a little bit about going where we go from here. And one of the things that we keep hearing is, again, if you're going to make these kind of investments, if you're going to actually not just turn around and go back to in person, which again is still iffy right now as to how safe it is for seniors or for anyone, you do need, and I think Natasha, you said this really nicely, you need clarity and you need certainty. And that's the only way that you start to see the kind of investments, the kind of provider engagement and beneficiary engagement in it going forward. So it's definitely on our radar screen that we want to actually be able to do that. So the things I think we will need some help from providers such as yourself to really figure out how much flexibility we're going to be able to get and how we can articulate the reasons. So we'll need your help on some of that too going forward, because there is still, Natasha pointed out, real concerns about this. Jonathan, do we have another question?
Yes, we've got a question from Anthony, and he asks, any insight about how telehealth will further integrate wearable devices into virtual appointments? Will this directly affect reimbursement based on overall health for this population?
Who wants to take that one? Any thoughts about that? They're thinking about it. It was an interesting question.
Yeah, it's a great question. And, remote monitoring and sort of collection of data, patient data from the home or in, vitals, be able to have vitals on a patient really helps improve the scope of what providers feel comfortable doing. I'm not a provider, but in my observations and conversations, that makes a big difference in their comfort of what they're willing to do in terms of treatment and diagnosis remotely. I think the challenge is what, blood pressure and the HEDIS metrics around this, right? And whether they will accept a remotely recorded blood pressure reading, for example, and in what situation. So this is where we really need regulators and quality agencies to align. And I'm sure that this will come. We're in a bit of this uncomfortable time, I think, where the technology is in one place, the regulation is in another, the HEDIS and STARS metrics, the risk adjustment is in another place, and the stars need to align here, right, for everything to get going. So I don't have the answers, but I think it's a really great question, and we're all watching that.
Although you sort of provided it, which we need some clarity about this, is that if you provide remote monitoring devices, what's accepted, what's not. For risk adjustment, clearly that's important. And as back to what Allison talked about, I don't want to say anything more about this, but the importance of audio only is really quite clear for risk adjustment, at least this year and next, because we just don't let it, so many, if you're talking about 30% of your patients, in some cases more. For a while there, it was much more. I mean, some of the numbers are so staggering when you think about going from 400 a week to 10 or 13,000 it was a week. It's like, I always check those numbers. Could that be right? But it's exactly what was happening. But those people may not be back for another visit if they don't need to be, or they might be, so not being able to use that, but not being able to use some of the remote monitoring. I mean, right, for actually, should they say you need a lab test or you need some kind of diagnostic measurement, we're going to need to get some clarity about does that count or not. But I assume there's also some clinical judgment in this too. If you have someone who really can't read their monitor, obviously there will be people who can't. But again, I think some of the technology there might grow where some of that remote monitoring goes directly to someone. There are companies out there doing that. You may be doing that to some of yourself where you're not relying on the patient to read it and understand it. It's actually going somewhere where a clinician can actually read it, in which case can be some judgment made about it. That's a kind of a bit of it's been starting, but a bit of a new world. Yeah, that's for sure. Phil, Allison, did you have anything more you wanted to say about how this all integrates? At least star ratings matter to plans as well. You want to be that 4.5 star plan if you can be. So they don't want to fall behind in a way that isn't consistent with what they're seeing or have to practice during particularly this next potential year during COVID.
Yeah, I would just say that from a clinical perspective, just getting those data do extend what you can accomplish. And I think there are a lot of questions around the veracity of the data, how to best use it, how to not overinterpret it, who gets devices and who doesn't. But I suspect that in 5 years from now, that will be part and parcel to what we're doing all the time.
Right. Yeah. We'll have an app if we can help us through. Jonathan, anybody else? Otherwise, maybe we should wind things up.
It looks like those are the only questions in the queue right now. So we could move on to closing remarks if you'd like.
Absolutely. All right. Well, my closing remarks is thank you. Thank you very much for a very content-rich and textured conversation we've had. This is always very helpful. So I remember from my my years on the Hill, but even what work we do now at BMA, we want the numbers, but really hearing what had to happen during all that time. And of course, this report did reach out to providers and plans, and really those interviews, we weren't so sure how much we would get from those interviews, but it's been really wonderful, the degree to which providers and plans and beneficiaries want to talk about this and want to share their experiences and want to enable policymakers to learn from it. So thank you for taking care of us during COVID and taking care of your patients, and Allison for the good work you've done on this report. And we will send this report out to everyone on the call. We had a very big interest in this call, well over 100 people. I think it was 120 or 30 people who registered, which is really great. And we'll just keep gathering this information and working with policymakers to get that clarity and that certainty to enable this kind of innovation for your patients under Medicare Advantage. So thank you very much. Thank you to each of you.